Stretch for a minute as we get started. It's obviously impossible for me to go through this quick in 50 minutes. If we had an hour, we might be able to, but we'll try to get through about 9/10 of it. Basically, I think the guiding principles, unlike other parts of the body when we're doing head and neck radiology, is that it's like real estate. Anatomy is critical, and location is everything. And basically, if you can localize a lesion to the anatomic compartment in which it exists, there are typically only one or two or at most three things that it could be. So the trick here is going to be looking at some of these big principles of how you compartmentalize some of these lesions. And that's what's going to be your big clue as to what these are. And we're going to try to cover cystic lesions of the head and neck. We're going to look at lesions of the larynx, orbits, Pterygopalatine, Fossa, sinuses, skull base. I know it's a lot to cover in just a couple of minutes, but I'm going to talk very loud and fast. So I think one of the other things to keep in mind in this limited different is that in true clinical practice, unlike things like heart exams, most of the time, the clinicians are either going to know or have a pretty good idea of what the lesion is. So it's not so much of your listing this exhaustive differential diagnosis. What head and neck physicians, otolaryngologists want to know is how to guide their surgery. What stage of disease is this? Are bones invaded? Is cartilage invaded? How should I plan my surgical approach? Those are the type of concepts you should keep in mind as we go through these things. And so for head and neck, you could divide up the neck into anterior and posterior triangles. Branchial cleft cysts, very common anterior triangle. Cystic hygroma is pretty much anywhere else. I'm going to tell you how to distinguish them. Pretty much if you see a midline or a parasagittal lesion, there's really only one major thing it could be. Some of you probably already know it, but I won't give it away just yet. Lymph nodes, there is a differential diagnosis for enlarged lymph nodes, which we'll go through. If it's an isolated primary presentation with a node. And probably the most important thing we're going to review is this whole idea of the pre-styloid versus post-styloid parapharyngeal space. So we'll spend just a little time. I won't talk quite as fast, but just as loud when we get to that part. So let's start just with a simple midline cystic lesion on a T1 image. And this is basically a region anterior to the epiglottis here that is T1 bright. What things are T1 bright? Well, fat, blood, protein, gadolinium. In this case, this was something that's been like this forever, so it's probably protein. On T2, it's also T2 bright. Just in front of the hyoid, what is this? It's a thyroglossal duct cyst. There's not really a lot else it could be. Thyroglossal duct cyst developmentally starts at the foramen cecum at the base of the tongue, and as you develop, it can travel down with the thyroid gland, leaving a small sinus cavity, which may go out to the skin as well. It could be through the hyoid bone, behind the hyoid bone, in front of the hyoid bone. In addition to the cyst itself, which is formed by a pinching off of that tract that is left behind, you can also actually get ectopic or aberrant thyroid tissue, which probably does have a slightly higher propensity to form cancer than normal thyroid tissue. And so basically, it's midline or paramedian. If it becomes infected, it may not be a simple unilocular cyst. It could look like an abscess. It could be heterogeneous in appearance. It could be parasagittal, just around the thyroid cartilage, a little off midline. So don't get fooled if it's not precisely right in the midline. But certainly if it's below the level of the thyroid gland, unless of course you have mediastinal thyroid tissue, it's probably not a thyroglossal duct cyst because it has to be along that tract. And because it is formed by an invagination of that tract, to get rid of it, to treat it, you need a complete resection of the squamous lining, Most of these really occur below the level of the thyroid gland, and pretty much all the cystic neck lesions we're going to be talking about for the next 5 minutes or so are all in a pediatric or young adult population. Often they're completely asymptomatic until they become infected, and then they balloon out and become clinically obvious. All right? Here's another pretty much Aunt Minnie, but there are 1 or 2 very important things in the differential here. So if you could get the anatomic location on this one, this is probably what? First or second? Second branchial cleft cyst, very classic appearance, but there is a limited differential, especially if it becomes infected. So where is a second branchial cleft cyst? It's a simple, again, unilocular cyst, posterolateral to the submandibular glands, anteromedial to the, what muscle is this? Sternocleidomastoid. Simple unilocular cyst. If it has a thin wall and is homogeneous, you're pretty safe. There's pretty much nothing else it could be, especially if it's nice and round. On T1, it might have varying signal intensity depending on its proteinaceous content. And basically, first branchial cleft cysts are incredibly rare. They're the type of thing that some people build their academic careers on and become full professors debating whether they're really in the external auditory canal or part of the parotid gland. The bottom line is it really doesn't matter. If you see a simple unilocular cyst at about that level, that's probably a first branchial cleft cyst, but it's the second ones that are really much more common. Now, what if you have not a simple thin wall, but a nice thick wall like this? It expands the differential a little bit. And let me tell you a little kind of clinical pearl. Even in the brain, if you're trying to distinguish an infected abscess, say, from a brain tumor in the frontal lobe, one of the things you could do is look where the irregular margin is. If the irregularity and nodularity of a thickened margin is pointing in, that's probably an abscess, an infection. And if the nodularity and irregularity is pointing out, it's probably infection, it's probably tumor. So in this case, this was just an infected branchial cleft cyst, and you can see a lot of the nodularity and irregularity of the wall is pointing in. But there is some differential to this. And of course, when you're looking at a single image, you're not seeing the full length of this. Is this round and spherical? Is this more sausage-shaped? If, let's say this was sausage-shaped, let's say this ran all the way up and down the neck, anteromedial to the sternocleidomastoid. In this location, just around the carotid artery, the external carotid, internal carotid, jugular vein, what else lives in that anatomic location besides potentially a branchial cleft cyst? What normal tissues? There's nerves that run there, cranial nerve 9, cranial nerve 10, around that carotid sheath. So this could be a cystic schwannoma. On T2 bright can very often have that myxoid or mucinous appearance. So you should always have schwannoma in the differential of this appearance. And another thing that lives in that location is just lymph nodes. So whenever you see a big, round, centrally necrotic thing like this, you should always think, could this be a necrotic lymph node? A little less likely and common for it to be isolated. And of course, it depends on a lot of other things. But this actually, you see, has a focal large mass and more irregularity here that's both pointing out and pointing in. This was a large necrotic lymph node. And this was a patient with a squamous cell carcinoma of unknown primer. Right? Now, if it's not in that classic location, and there are multiple of them, then you clearly think lymph nodes. And in this case, this was scrofula. But what else is in the differential of multiple enlarged lymph nodes with central low attenuation, necrotic centers? You have things like cat scratch fever. You could have other general infections, other general cancer. But definitely think lymph nodes in that location. Now we move to a slightly different appearance. What if you have multiple different septations that are going into multiple different anatomic compartments? What is this? Cystic hygroma. What's a synonym for cystic hygroma? Lymphangioma, cystic hygroma mean the same thing. Very difficult to get rid of. Incredibly tenacious. They insinuate into different tissue spaces. Treatment involves some kind of sclerosis. You could give them antibiotics that are sclerosing agents. You can use ethanol, but very hard to get rid of. It makes it even harder to get rid of these sometimes is the fact that they are not only multilocular and tenacious, but they represent a spectrum. In the lungs, what develops, basically the arterioles and bronchioles develop together, and on the drainage side, what develops with the lymph system in the lungs? The venous system. So these often are not pure lymphatic malformations. These often fall at one end of another spectrum from arterial malformations or aneurysms or AVMs or capillary malformations. These are more generically known as lymphovenous malformations. And if you have a patient which may have one of these, you can ask them to do a Valsalva. You may actually see them blow up. And a good clue is just clinically, as the patient's getting in the scanner, you can look at the skin. Is it tinged blue? Is it tinged purple? So these often will have venous components which can look really T2 bright. And because they're slow flow, there might not be a flow void. You could get faked out. So if there's any question that you're going to sclerose this or treat this, you should probably give contrast before you do that to make sure there's not a significant venous component. That's the bottom line here. Okay, let's move on to floor of mouth. This muscle is the key anatomic landmark that separates the sublingual space from the submandibular space. It's a blind-ended muscle. It's kind of the best way to think of this is that this is the levator ani of the floor of the mouth. Okay, it forms a pouch. What's below the pouch is submandibular glands and digastric muscles. What's above the pouch are the paired tongue muscles, geniohyoid, genioglossus. Okay, so this is the sublingual space. There are minor salivary glands in here. There are major salivary glands in there. So on either side, you could get salivary type tumors. You could get salivary lesions. If one of the ducts of these salivary lesions gets blocked and it balloons up and becomes a cystic lesion, what is that called? That's called a ranula. Okay, then there's the term diving ranula, depending on whether it's in the sublingual or submandibular space. Here you see one that seems to be starting in the submandibular space, then looping around the back of this mylohyoid muscle, around this blind-ended pouch, and breaking forward and coming forward. So it could be in two spaces. But it's unilocular, not multilocular, so you wouldn't confuse this with a cystic hybroma or lymphangioma. Again, we're talking about pediatric tumors here, at best in young adults. There is no fascial boundary around those diving ranulas, so there's nothing to break through there. It might leave a little tail. And again, there arises post-inflammatory retention cysts, usually starting in sublingual space, moving to submandibular, but they could go in either direction. Here's something that you might think is a ranula, cystic lesion out laterally. Not quite clear if it's submandibular or sublingual. But again, you're getting one snapshot here. You always have to follow up and down, look at the full extent of the lesion. And if you follow this all the way down, you actually see it's breaking through the thyroid cartilage. There's a cystic lesion in the midline that got so big it kind of just dissected up into the submandibular and sublingual space. So this isn't ranula at all. What's the point of origin of this? What is this? This is actually a thyroglossal duct cyst that just got so big it kind of dissected up. So again, look at the whole lesion. If things are in multiple different spaces and multicystic, it's easy. Think cystic hybroma. If you think cystic hybroma, give contrast. You can treat to make sure there's not a venous component. And then other things you'd look for is infection, ranula, hemangiomas are fairly common. Let me just make one point when you're distinguishing. This was actually a cystic hybroma, not a ranula as well. You have to certainly window correctly, look for those septations. Cystic hybromas are developmental malformations. Again, lymphovenous malformations. They will not spontaneously regress. They are hard to treat. Pediatric hemangiomas are true tumors. They are neoplasms of the sinusoids of the blood vessels. And in pediatric age group at least, hemangiomas often spontaneously regress. So those are something that may just watch and wait if someone is born with them. But lymphangiomas you have to treat. Let's just talk very briefly about lymph nodes. Basically, there is a numbering system for lymph nodes. 2, 3, and 4 are along this jugulo-digastric chain, or this carotid sheath, or this anterior triangle. 2 is basically high jugular above the hyoid. 3 is from hyoid to cricoid, and 4 is below the level of the cricoid. The actual anatomic definitions of these are really based on where like the omohyoid and other muscles cross the sternocleidomastoid, but these landmarks of hyoid and cricoid are good enough. Why do you need to know this numbering system? Sometimes if you're at a place with a lot of head and neck, especially if they're enrolling patients in clinical trials, they have to use these numbering systems as inclusion criteria. But again, 1 is floor of mouth, 2, 3, 4 is this jugulo-digastric chain, 5 is posterior triangle behind the sternocleidomastoid, 6 is around the thyroid gland, 7 is the tracheoesophageal groove. By the way, what nerve ascends in the tracheoesophageal groove? That'll be important later on. The recurrent laryngeal nerve ascends in the tracheoesophageal groove. So if someone comes into vocal cord paralysis, you always want to look around the tracheoesophageal groove all the way from mid-mediastinum up to the skull base. We'll get to that later. Okay? There's one node that is Dr. Eucurnan's favorite node, probably deserving of special reference, the node of Rouvier. In general, lymph nodes that are abnormal, enhanced, they're slightly T2 bright, they may have necrotic centers. There's probably 3 criteria you would use to describe an abnormal, potentially malignant lymph node: size, shape, and internal density. Size, if it's in the jugulo-digastric chain, short axis dimension over 1.5 centimeters, anywhere else in the head and neck over 1 centimeter. Shape, the more spherical it is, the more likely it is to be malignant, and the more internal necrosis there is, the more likely it is to be malignant. If you have all 3 of those, you have over a 90% chance of malignancy. Any one of them is probably about a 75% chance, and you can kind of mix and match. Of course, the best way to gauge lymph nodes is this whole up-and-coming iron oxide thing with myons that you may have heard something about, but that's still work in progress. So why do I especially point out the node of Rouvier? Because that is a sentinel node in adults for nasopharyngeal carcinoma. In children, it's often common with all the infections they get and all the adenoidal tissue that they have to have some enlarged lymph nodes. But in an adult, when you have a focally enlarged node of Rouvier, especially in an Asian population, think nasopharyngeal carcinoma. It's a sentinel node for nasopharyngeal carcinoma, Asian population, EBV virus associated. Now we're getting to the part that I said I want to just slow down just a little bit, this whole pre versus post-styloid parapharyngeal space. The reason that's important is that if you can localize something to the pre or post-styloid parapharyngeal space, it helps to tell you what it is based on the tissue that lives in that space. And so essentially what we're talking about is the styloid process really typically runs just lateral to the carotid sheath. So if you're working with a CT and you can see the styloid process, that's great. If you're working with an MR and you can't see the styloid process, then if you use the carotid sheath, you can pretty much make the same assessment. And basically, what lives posterolateral to the styloid process in the carotid sheath? Well, it's pretty much nerves. We talked about the vagus nerve, cranial nerve 10, glossopharyngeal nerve, cranial nerve 9 is in that carotid sheath. There are some lymph nodes back there. So if you see a lesion back here, you're thinking neural-based tumor from the cord. You're thinking a potential lymph node, especially if it's more lateral. Now, what if you're in this anterior, pre-styloid or pre-vascular space? Well, in this pre-styloid, PPS, pre-styloid parapharyngeal space, there's only 2 things that live: fat and salivary tissue. Deep lobe of the parotid gland, small salivary rest cells. So if you were to see a lesion right up here in the nasopharynx, in front of the carotid sheath, in front of the styloid process, it's pretty much always a salivary lesion. Just based on location, that should certainly be your first thought. And so that's the type of assessment you're trying to do based on this anatomy. So let's analyze this case. This is kind of a big, kind of homogeneous looking, low density mass, not really enhancing, maybe some spotty enhancement. Here's the internal carotid, the external carotid, and here's the jugular. So it's not really splaying them. It's not between them. It's just kind of displacing them anteriorly. So in terms of the vessels, carotid, external, internal, this is post-styloid. What was post-styloid parapharyngeal space? Nerves and lymph nodes. What could get to be a big, homogeneous, mucinous, myxoid-looking lesion like this that lives in that location? Schwannoma. Or some kind of other neural-based tumor, maybe a neurofibroma, maybe a ganglioglioma. This actually turned out to be a ganglioglioma, but could have just as easily been a schwannoma. And this is just pretty much a word slide summarizing what I just said. On the other hand, here's a different looking lesion that you have to go up and down to see this. It's not projecting well, but this lesion is actually splaying the external and internal carotid. And it has more of an irregular, patchy, flovoids, salt and pepper type appearance. What is that more likely to be? Glomus tumor, carotid body tumor, splaying the internal and external. What are the properties of a glomus tumor? Very highly vascular, almost always has supply from the pharyngeal branch of the external carotid artery. Usually has to be embolized pre-op because they'll bleed like stink, very highly vascular. Rule of tens, like pheochromocytomas. 10% bilateral, 10% multiple. Always look for others along the course of the vagus. Glomus vagales, glomus tympanicum, glomus jugulare, etc. Okay? Another thing that you always, if you forget, I'm not teaching for boards now, I'm teaching for life. If you ever forget everything else I say in this lecture, just remember, when you are looking at a head and neck lesion, if there is any doubt whatsoever before you biopsy it, that it may be either a carotid artery that's aberrant in its course or a carotid artery aneurysm, just give contrast and find out for sure. And I will tell you that every funny case I'm going to show in here that turned out to be a vascular mass was something that was sent to Mass Eye and Ear for biopsy. And before we biopsied it, we gave some contrast. So this was, can you please biopsy this parapharyngeal mass, which we think may be a squamous cell cancer of a lymph node, and you give some contrast, and it's just a very medial course of the carotid artery, what's called the kissing carotid. We're going to keep coming back to this theme, at every level along where the carotid artery may flow, just give contrast if there's any doubt that something may be a carotid. And when you're looking for flow, by the way, CTA is always better than MRA, because you're actually filling that lesion with contrast. And even Gatto-MRA still has a lot of flow-related artifact, so it's never as accurate as CTA. All right, here's a lesion. Here's the, what do you call this vein that's just behind the mandible? The retromandibular vein. Why is that an important landmark? Because not only does it separate the deep and the superficial parotid gland, but what nerve always travels in this space just behind the retromandibular vein? Facial nerve always goes through the parotid, separating deep and superficial parotid just behind retromandibular vein. So here's a lesion in the, here's the carotid sheath, here's a lesion in the styloid parapharyngeal space, T2 bright, some T1 dark, some delayed filling in and enhancement, maybe a little bit of necrotic center, but definitely part of this pre-styloid parapharyngeal space. So first of all, it's probably part of the deep lobe of the parotid. Second of all, what lesion would be the most common parotid neoplasm to be pretty much uniformly T2 bright? 50 to 80% of the time, this is going to be a benign parotid pleomorphic adenoma, also known as benign mixed tumor. That's a synonym. Over 80% of the time. Does this need a needle biopsy or an excisional biopsy? Excisional biopsy. Why do you still have to take it out, even if it's going to turn out to be a benign mixed tumor? Because most of these, it may be 10 or 20 years later, but ultimately, if they're in long enough, they're going to degenerate into carcinoma ex pleomorphica, the cancer formerly known as pleomorphic adenoma. So you want to make sure you completely take it out. Okay? What else is in that differential diagnosis of T2 bright parotid lesions? Well, it could just be lymph nodes. A single lymph node isn't going to be that big and irregular. If it's multiple and bilateral, in addition to lymph nodes, it could potentially be what's called a Warden's tumor. That's probably the one thing you could leave in. If you see multiple T2 bright lesions in both parotids or both lacrimal glands or other salivary glands, if you biopsy one of them and it's a Warden's tumor, you can probably just watch and wait and leave the others alone because they're benign. Okay? Any malignant tumor is still going to be T2 bright. The difference between pleomorphic adenomas and other malignant tumors is that pleomorphic adenomas are like hemangiomas in the liver. They have this very slow, delayed enhancement and kind of fill in from the periphery. Most tumors, and what is the mnemonic for those malignant tumors? It's the same as for bronchial lesions. You know the CAMP, the CAMP mnemonic? Ciliandroma, adenoid, cystic, mucoepidermoid, or pleomorphic. It's the same as for bronchial adenomas. It's the mnemonic for epithelial lesions, epithelial tumors. Okay, so those can still be T2 bright, but those enhance very homogeneously and immediately, very rapidly. All right, so the bottom line is, unless it's multiple bilateral T2 bright lesions and you biopsy one of them and it's Warden's tumor, or you're following it because you think they may be lymph nodes, pretty much any other parotid single large lesion is going to come out anyway, whether it's benign or malignant. Okay? What if you have bilateral diffuse parotid gland involvement? Well, then you can think about microcysts, maybe lymphoepithelial cysts. Who gets those? HIV positive patients. They could be of varying sizes, or then you get to your whole category of Sjogren's syndrome, you know, all these connective tissue diseases that you can see with rheumatoid arthritis, and SLE, and other collagen vascular disorders, Nicholas syndrome, etc. So this is actually an HIV positive patient that not only of the parotids, but of all the other salivary glands, the submandibular glands as well, have these bilateral lesions. All right? So I think that's enough head and neck for now. Let's move on to larynx. Larynx is really true that the clinician almost always knows what they're looking at. You know, somebody comes in with either a mass or a vocal cord lesion, changes in voice, they're going to get looked at endoscopically. And I will tell you, in the entire larynx, nasopharynx, hypopharynx, if you're looking for a mucosal lesion, how many people think the radiologist is more accurate? And how many people think that the endoscopist is more accurate? And basically, you can miss, even on a good high-resolution CT, 3 to 5 centimeter fungating masses in the larynx or in the nasopharyngeal mucosa could be missed because they average in with the tongue and with the uvula. And you always want to say in your reports, if you're looking for primary detection, there is never an excuse not to screen a patient with laryngoscopy or a true look at that mucosa. We're getting this because 2 reasons. One is, normally the laryngoscopy the subglottic region as well, what's hiding under the cords. That's a blind spot. And number 2, because they know that cancer's there, but they want you to stage it. That's the reason that you're getting these. Okay? So how do you think of the larynx? Think of it as a bilaterally symmetric frame made of cartilage, fastened by ligaments, draped over by mucosa. And there's all these paired or midline cartilages that are associated with it. What is really crucial, especially since we only have about 20-25 minutes left, is critical for staging, is this division between subglottic, glottic, and supraglottic. Okay, and the reason that distinction is critical is because it actually determines whether voice-sparing surgery can be performed. The vocal cords are relatively avascular, don't have a lot of lymph nodes, don't have a lot of lymphatics. If someone is lucky enough to have a primary laryngeal cancer present with a change in voice, you could usually spot it early enough that it's restricted to just one vocal cord. If it's either subglottic or restricted to one vocal cord, you can often do voice-sparing surgery. So if it's entirely supraglottic, you just take out the side with the cancer and do a supraglottic hemilaryngectomy, spare the voice. Even if it's involving just one cord on one side, you could do what's called a vertical hemilaryngectomy, where you take out half the box, but then you can do some reconstructive surgery, put a little silicone implant in here, and the remaining vocal cord still has something to vibrate against. So you can still generate a voice. Okay? What is automatically stage 4 and requires a complete laryngectomy is if there is any subglottic involvement, any cartilage involvement, or bilateral true vocal cord involvement. That just gets a hemilaryngectomy, a complete laryngectomy right off. So how do you tell that? The most useful image is usually the coronal image. And in the coronal image, what is the most useful feature is the fact that the false vocal cords, the supraglottic cords, above the laryngeal ventricle. This laryngeal ventricle is a little air space. Above that, on pre-contrast T1 coronal, there's a lot of fat. Fat is your friend. Fat is T1 bright. And below that is just muscle. The thyroarytenoid muscle holds up the true cord. And then this little laryngeal ventricle has little mucus glands around it that keep the voice moist, that keep the vocal cords secreted, which my little laryngeal ventricle is probably drying out right now. But that's what it does. That's what it does in there. And it's that laryngeal ventricle, that little air space that separates the supraglottic from the glottic from the subglottic space. So that's kind of your critical imaging landmark. And if you have a tumor running down, be careful because the cartilage, if you're given Gatto, can be bright on T1. But if you have even a little tumor running down below that laryngeal ventricle level, below the level of where that fat is, then that automatically becomes stage 4. Okay? I said there's not a big differential. There is at least some differential. Often you can get a hemangioma in the soft tissues there, especially in younger people. So you should consider that. Papillomas on the mucosa, hemangiomas, especially along the trachea in the subglottic airspace. And you also always want to look at the cartilages. You could get a chondrosarc forming a mass. And if it's submucosal, then that's the one place the endoscopist is not going to be able to evaluate. Okay? Now, what if it really is a pure cystic lesion, either totally within the thyroid cartilage, around the level of those mucus glands, kind of the same as a ranula, and it can actually break through the thyrohyoid ligament or the thyrohyoid mucosa and go outside along the margin of the thyroid cartilage as well. That's called the Laryngocele. It could be air-filled or fluid-filled, and it's formed when there is an obstruction of those little mucus-secreting glands that I said live in this airspace, that are meant to keep the thyroarytenoid muscle and the true cords moist. And so if those become obstructed, which can happen just like in a ranula, they'll blow up and form a cystic lesion. You should always check to make sure there's not a cancer there, but 95% of the time there isn't. This is especially seen in people that have high intraoral pressure, glass blowers, trumpet players, people with COPD. Rumor had it at one point Monica Lewinsky had one of these. Always, though, check for obstruction. Look for the squamous cell cancer. Okay? This next thing I'm going to show may seem very obvious, but the reason I show it is that it's been known to show up in certain hotel rooms in Kentucky. And almost every year, one of our residents sees one of these. It's just laryngeal trauma. But it's important to always look very carefully for cartilage fractures. Because if you don't treat this, not only can it hurt the voice later on and get very difficult to repair, but if you don't treat it, it could blow up into a big, almost chondrosarcoma-looking exuberant reaction. And you wouldn't be able to tell it from a tumor because it could mimic a tumor. So you could also get, after trauma, laryngomalacia, stenosis of the airway, erosions. After intubation, you could get that as well. So just to be on the lookout for it. This is more of an eye test, but definitely be on the lookout for it and realize that granulation tissue can mimic a tumor in these healing reactions of these things, all right? We don't have enough time to go into detail about vocal cord paralysis, Just remember that the vagus nerve gives rise to the recurrent laryngeal. On the left, on the side of the ductus, it's going to loop around the ductus arteriosus. So if you're asked to image for vocal cord paralysis, you really have to go from the skull base, where the vagus nerve exits, at the jugular foramen, all the way down to the bottom of the mediastinum. On the right, it's just going to wrap around the subclavian and become the recurrent laryngeal nerve off the vagus, so you don't have to go as low to the right if it's a right vocal cord paralysis. And then it arises, we said, in the tracheoesophageal groove, so you're going to look along the carotid sheath for the descending vagus nerve, and then it loops posteriorly and comes back up and rises in the tracheoesophageal groove. So you're going to look for lesions in all those locations. Lymph nodes, vascular aneurysms in the mediastinum, etc. Let's try to fly through the orbits. The only really important anatomic distinction in the orbits is this preseptal versus postseptal space, because that's a true barrier to infection. Okay, infection will stay preseptal, but not break postseptal. You'll also talk about intraconal and extraconal based on where the muscles are, but not as important functionally as an anatomic boundary. This is in your notes, just some anatomic landmarks. I'm going to leave these for you to go through on your own. In terms of important disease processes, bilaterally, symmetrically enlarged extraocular muscles, painless usually, dysorbitopathy. What is this? More likely than not Graves' disease. What's the order of muscle involvement? I'm slow, inferior rectus, medial rectus, lateral rectus, classic. But always think of pseudotumor. Pseudotumor more likely to be asymmetric, more likely to be painful, more likely to be responsive to steroids. Pseudotumor is actually almost like an inflammatory process. So there's going to be a lot more pain, stranding of the fat, etc. Okay? Basically, with the thyroid orbitopathy, all you really have to remember is it could become clinically symptomatic before, during, or after you are clinically hyperthyroid. And it also is formed by these immunoglobulin deposits, this long-acting thyroid stimulator that circulates. If you have any other irregular muscle involvement, always think pseudotumor, which is what this is, but this could easily be a lacrimal mass as well. If you see a mass that is going through different spaces, we talked about preseptal versus postseptal, bridging those spaces. Lymphangiomas can happen in the orbits. Venous varix can happen in the orbits. You could ask the patient again to do a Valsalva. Look to see if the skin is purple on the outside. If you're thinking as B-cell lymphoma as a possibility, one good clue is that lymphoma is a very soft tumor. In the head and neck and facial structures, it will never indent the globe. This actually turned out to be a lymphoma. And pseudotumor to be similar, not indenting the globe, but just molding the globe. It actually does the same thing in the cavernous sinus in the case Dr. Bookbinder showed. So lymphoma molds the globe, does not indent the globe. All right. Whereas if you have a true benign mixed tumor of the lacrimal gland or a post-traumatic lacrimal hematic cyst from the subperiosteum here, that's going to indent the globe and push the globe and bend the globe and cause proptosis. If you have a low attenuation mass near the origin of the lacrimal duct, most of the time it's just an obstruction of the lacrimal duct, causing a little saccular region that's obstructive, but it can also be a very common location for a dermoid, around the base of the nose or just lateral around the nose, and that was actually a dermoid cyst. We talked about the fact that hemangiomas are true tumors. They envelop children, whereas cystic hygromas can look like anything, multilocular, different departments. Also, the other thing about cystic hygromas that I didn't mention earlier when we were talking about lymphangiomas is that they also have a very high propensity to bleed and or calcify, especially when they're in other locations. Something else important to keep in mind about lymphangiomas. Much more common than other lesions to bleed or calcify. And again, because they have that venous association, because they're at that end of the spectrum of those lymphovenous malformations. So the last image was with contrast, and you can see there is some hemorrhage when you get the image without contrast. And this was a big lymphangioma that went through all these different spaces. Now, this looks like it could be a lymphangioma. It might be a lymphoma molding the orbit, but there's a clue here. There's sphenoid bone dysplasia, which actually makes this an Aunt Minnie in a child. So what is this? NF1. All right, that's a neurofibroma. In the same way that in the tibia or femur, you could get a long gracile bone. You know, you get sphenoid bone dysplasia when you have facial neurofibromas. Okay, so that's just something to memorize. That's an Aunt Minnie kind of appearance there. When you have the bony dysplasia. The most common intraorbital mass in an adult is an orbital cavernous hemangioma. Okay, it enhances, it has all those vascular sinusoids. It's a true tumor, you can scoop it out. But you can also get intraorbital schwannomas that can easily also displace the optic nerve like that. Mets could be in the globes in adults. If it's a true lobe mass centered in the retina or in the choroid, think melanoma. And that would also be T1 bright, either from T1 bright signal intrinsic to the melanoma or from hemorrhage. All right, other things. This was actually a schwannoma, again, more tubular along the course of this and growing all the way up to the globe. And this is another Aunt Minnie. This is what's called a tram-tracking appearance. We have an enhanced, on a fat-suppressed image, you have this enhancing lesion sitting along the course of the optic nerve, encasing it. What is this? Yeah, this is a classic Aunt Minnie. This is an optic nerve meningioma. The only other thing to be aware of is if you're looking for optic neuritis, which is not usually a radiologic diagnosis, you should definitely try to get coronals. Look along the optic nerve on coronal T2s to see if there's asymmetric brightness, or STIRs or T1s to see if there's asymmetric enhancement. If it's along the optic chiasm and you have an enhancing mass, in child, what is that? An optic glioma. Often seen, and a thing to remember about optic gliomas is that they're pilocytic histology. So if you have to have a glioma, a pilocytic astrocytoma is incredibly benign. So these kids actually do well. You could scoop these things out. There may be some visual problems, but they're not going to die from their glioma. This is very treatable. And here's just some asymmetric enhancement in optic neuritis, which optic neuritis is the first presentation of what disease? Multiple. And once someone presents with multiple sclerosis, 80 to 90% of the time, they go on to develop optic neuritis. Again, if you're shown ever as like an exam type question, what looks like sinusitis, but then there is a low density raising through this lamina propria. What does lamina propria mean in Latin? Paper plate, paper thin. There's these little valvulus veins going here. If you had a true bacterial sinusitis that was left untreated, very easy to get a subperiosteal abscess in the orbits. And we still see it, and just to recognize it. Lifting the muscle like that. Okay? All right, Pterygopalatine fossa. Again, I'm going to leave you guys to study the anatomy. I could give a whole 2-hour lecture on the anatomy of the Pterygopalatine fossa. A really fascinating topic. It basically is the crossroads between the brain and the face. And the only important tumor you're going to see there is in adolescent males who present with painless epistaxis. And what are they going to have? So even on a plain film, you're going to see bowing of the maxillary sinus posterior wall anteriorly by a big soft tissue mass sitting in the Pterygopalatine fossa behind the maxillary sinus. Almost looks like a glomus tumor, very heterogeneous, ugly, highly vascular, always applied for the sphenopalatine artery. It's a juvenile angiofibroma. The only time you'd ever give a differential diagnosis if it was really centered in a different space. You have a kid coming in with a lesion that looks like that, but it's centered in the bone and not arising from the posterior wall of the nasal cavity or from the Pterygopalatine fossa, but arising from the bone and displacing the fat in the Pterygopalatine fossa, which is your clue. Then you might think, well, what are malignant-looking bone tumors that kids get? You know, Ewing, rhabdomyosarcoma, but even more common would just be EG. And when we've seen this appearance in the past, it's been eosinophilic granuloma. All right? And again, all kinds of spaces. And I think the main thing to remember is that it gets pre-op embolization, just like glomus tumor, because it's so highly vascular. It always gets supply from that Thyroglossal artery, which is the terminal, it's like the seventh son of the seventh son. It's the terminal branch of the external carotid artery. The terminal branch of the external carotid artery is the internal maxillary artery, and the terminal branch of the internal maxillary artery is the Thyroglossal artery. Okay? Sinuses. Again, I could give a 3-hour lecture on sinuses. More fascinating topic. If you think you ever see a tumor, they're very uncommon. So my usual answer is, if a clinician asks me, is that a tumor? I usually say, no, it's snot. Get it? No, it's not. All right. It's like that. So I got to get through all the temporal bone and sinuses in 5 minutes. We'll do it. We'll do it. Okay, I'm going to talk a little faster. Basically, again, important anatomy is this osteomeatal complex. Okay? And basically, the uncinate bone here, the drainage pattern is infundibulum, semilunar hiatus into the nasal cavity. The way to think of the nose is that there's a central hole called the piriform aperture going into the central cavity. The central cavity is lined by paranasal sinuses that do the aeration, etc. The cilia beat towards this infundibulum. So if cilia always beat towards this infundibulum, the old surgery, where they used to go in over the teeth through the maxilla, called the Caldwell-Luck resection, was never a physiologic surgery because the cilia still beat towards the osteomeatal complex. So now with endoscopic sinus surgery, things work much better. Okay? And basically, you know, if you see air fluid levels or circumferential thickening, think sinusitis. If there's bony sclerosis, chronic sinusitis, lots of patchy destruction, osteomyelitis, expansion, demineralization, thinning, but with a homogeneous looking mass. Mucus tumor usually has both soft tissue mass and bony destruction, and fungus could be calcified, mineralized. It could have iron, magnesium deposition. It could look very, very dark on T2 because of all this inspissated secretions. And polyps may be indistinguishable. Antropoidal polyps may be indistinguishable from inverted papillomas. So again, you see the soft tissue mass going through the bone, destroying the bone on either side of the bone, that's probably tumor. But tumor, again, is very, very rare. In the sinuses, basically, most of the time when you do see it, it is a squamous cell carcinoma. On the other hand, this can easily be an angiocranial polyp, but if it's an isolated mass in the maxillary sinus coming up into the nasal cavity, think inverted papilloma, especially if there's no other sinus disease. All right, that's a microscopic distinction. You know, it's not grossly inverted. It's microscopic because the endothelium is endophytic. All right? Now, just like other lesions, it could degenerate into squamous cell, so it's important to recognize it and take it out. All right? What if you have a lesion that's at the olfactory groove or at the cribriform plate that either grows up in the brain or down into the sinuses? That's probably the only other important tumor, olfactory neuroblastoma or esthesioneuroblastoma. Okay, those are all nice. The only thing you're likely to see on an exam situation is a mucocele. And people see them every year. Again, expansion of bone, but not lytic destruction, homogeneous cavity, formed by, just like the ranula, obstruction of the sinus ostium, more common frontal, less common maxillary. Car intensity is usually uniform, but depends on the hydration. And don't get faked out if it's going, there are all these little bones in here. It could still be a mucocele and kind of grow around some of these thin little paper-thin bones in the ethmoids and the sinuses. Sinuses, skull base. Again, I'm going to leave the anatomy to you guys in just the 2 minutes that I have left. I'm going to just go through what really the major differential diagnoses are in this location. Okay, so this is pretty much an ant mini. In the petrous apex, is you have a T1 bright expansile mass that does not enhance, may or may not be T2 bright as well. What is it? Cholesterol granuloma, also known as cholesterol cyst. Okay, not to be confused with cholesteatoma. Cholesteatoma is a completely different entity. The cholesteatoma is basically skin cells. It's epidermis. and its epidermis in the wrong place. So when you have it growing in the middle ear, it could keep growing, and cause hearing problems and grow right into the brain. When you have it in the petrous apex, which is much less common, it will do the same. Okay? But basically, in fact, what do you call cholesteatoma? What's a synonym for cholesteatoma when it's in the brain? It's actually called an epidermoid. They're synonyms. For some reason, when it's in the brain, people call it an epidermoid. When it's in the middle ear in a kid, people call it a cholesteatoma. But it's skin cells. Okay? Cholesterol granuloma, cholesterol cyst is completely different. Cholesterol granuloma is basically a mucocele. But instead of being in the frontal sinus, it's a mucocele of the petrous apex air cells. Why is it T1 right? Proteinaceous content, fat content, cholesterol. Okay? All right? It's in pneumatized petrous apex air cells. And because it doesn't have a mucosal lining, you can just marsupialize it to treat it. And it's cured. Okay? What did I tell you at the beginning? If you have anything in a location where you're suspicious, this was the bone windows of that cholesterol granuloma I just showed you, separate from the carotid canal. But then we had another lesion like this that got sent into us. True story, got sent into Mass Sinai. Cholesterol granuloma, please drain. We have some contrast. And the format of the cavern of the carotid as it goes through the petrous apex in the petrous canal. So again, just keep in mind, give contrast if something might be a carotid lesion. Another common skull-based lesion is a glomus tumor. Very useful rule of thumb. You guys can last another 5. I'm a little over, but you guys can last another 5 minutes. We can finish in 5 minutes. Is that okay? Okay. Very useful rule of thumb is a bony skull-based lesion, permeative, destructive, lytic lesion, right in the midline, in the clivus. What is it? Chordoma. At MGH, we have a chordoma clinic, so we think everything is a chordoma. It's not. And if there's something's off the line, what's a far more common skull-based lesion than chordoma? Chondrosarc. Usually it's a skull-based lesion. Get the CT, look for your rings and arcs. Why are chondrosarcs so common in the skull base? Because you have all these cartilages. Developmentally, everything was the petroclival synchondrosis or the petrosphenoid synchondrosis, or there are all these synchondroses that are all cartilaginous. So there's an awful lot of places for chondrosarcs to arise from. Again, look for the rings and arcs. Glomus tumor is also very common. Again, depending on how advanced you are, you've looked at Arnold, in the glomus tympanicum, in the tympanic cavity, in the jugular foramen. But they're a long course of the vagus, okay? Chondrosarc does not have to be in the clivus. Chordoma does not have to be in the clivus. It could be in the C-spine or in the sacrum. It could be off midline, not directly midline. Why is it often has mucinous gelatinous appearance? It often has this mucinous gelatinous appearance because of the cell of origin. It's notochord remnant. What else is it? Nucleus pulposus, intervertebral discs. It's the same cell of origin. Just for extra credit, it's called the phyllosiferous cell. All right? A nice piece of trivia. If you reach the point where your examiner asks you what a phyllosiferous cell is, you know you passed. I wouldn't worry about it. Here's a skull-based lesion on non-contrast skin. It's hard to tell from this whether this is centered in the bone, whether this is centered in the CSF. This could be an epidermoid. You know, if it was an epidermoid versus arachnoid cyst, what sequence would you want to do? Diffusion to tell the difference, because free water would not have epidermoid would. But you give some contrast, and you see that it has a funny enhancement, so it's probably not an epidermoid. Now I'm thinking more chondrosarc. And I get the CT, and yeah, there are rings and arcs, chondrosarc, okay? Basically, okay. So basically, what else is in the differential? Not much for this. If you really want to get to PhD level, there's something called endolymphatic sac tumors that are in the vestibular aqueduct, Laryngocele, that live in the vestibular aqueduct that could look just like this. And that's probably everything that's in the differential diagnosis for this. All right, we're on like our last 2 minutes. Temporal bone. Okay, again, you could go through anatomy on your own. External auditory canal, middle ear, inner ear, 700 auditory canal. All these things are handed out, they're all labeled. You know, certainly you gotta know the real buzzwords like the sputum. Prusac space is the space between the ossicles and the sputum. Why is that little air space so important? Because that's where cholesteatomas live. By the way, looking at an axial image, if you just find the middle ear ossicles and then find the bone lateral to that, you know that's Prusac space. So it's easy to find the sputum and Prusac space on an axial image. Just find the ossicles, go out laterally. The bone just outside the ossicles is going to be the sputum. All right? That's cholesteatomas, which are acquired cholesteatomas. How do cholesteatomas get in there? Well, some are congenital. They're just little epidermal rests that wound up there. Some you can push it. More often than not, it's just from the eustachian canal, and they just get brushed back into the middle ear. So they're acquired. They're secondary. All right. Another thing, just forget everything else in the syllabus. Just listen to this for a minute. When you see fluid or soft tissue in the middle ear in a child, it's otitis media until proven otherwise, unless there's bony scalloping. And if there's bony destruction and bony scalloping, it's a cholesteatoma until proven otherwise. When you see fluid or membrane thickening or soft tissue in a middle, most adults get otitis. So if you see it in an adult, you have to, where do you look next? You look in the nasopharynx to look for a cancer, and you tell that patient to get a laryngoscopy. Because more often than not, there's going to be a little cancer that's blocking the eustachian canal and making fluid filled up in the middle ear. So that's very important in that location. That's something you want to look for. Most of the time, they already know they have cholesteatoma. A good otolaryngologist is going to look in there, sputum is up here, bar malleus over here, this upper corner of the air space in the middle ear, bulging white pearly tympanic membrane, that's a cholesteatoma. They don't need you, the radiologist, to tell them that they're looking at it. They see it. What they want you to tell them is, what cholesteatoma is this guy's temporal lobe going to come pouring out? Okay, if you unplug it. So they want to know, is the roof, the tegmen tympani, the roof of that area dehiscent into the middle cranial fossa? They also want to know, is the wall covering the lateral semicircular canal intact? Okay, if the wall is dehiscent and they pull out this cholesteatoma, you're going to have unremitting vertigo, you're going to have an lymphatic leak. Air cells are going to be stimulated, and the patient's going to wake up with nystagmus and vertigo. That's not good. So how do they cure that? Well, they just take out the whole labyrinth, and then they won't wake up with nystagmus and vertigo. And the other side is good enough. You know, you'll still have your bowel, but at least you want to nystagmus. And you're also looking at this little kind of space over here called the facial recess, because they want to know for their surgical approach, are they going to go near the facial nerve? And again, I'm not going to get into all that anatomy. Last topic, bulging red tympanic membrane. Differential diagnosis is a glomus cochleaform process, glomus tympanicum, which can sit right on the tympanic membrane and make it bulging red. The tympanic membrane runs from the sputum to the tympanic annulus. A little glomus tympanicum could sit right on there and cause a bulging red tympanic membrane. But the one thing, again, you want to watch out for is an aberrant carotid artery. Normally the petrous carotid canal ends here. If it sits up against the tympanic membrane and you try to take it out or biopsy it, you're going to have an arterial bleeder and cause a stroke and a dissection. And again, another case that was sent to us, glomus tympanicum. There's a little, normally this is a smooth border on AP or lateral, and if there's a little nipple that comes out along the corner of the carotid artery, aberrant carotid artery, never, never, never miss that. If you see a bulging red tympanic membrane, something in that location. And CPA tangle tumors is really not head and neck, it's really intracranial, and you should be able to tell these apart. Melanoma, meningioma, epidermoid, never be confused. Within the internal auditory canal, usually you could have acoustic neuromas. very, very rarely with non-expansile lesions. You might have a meningioma. You can answer it with herpes zoster, facial hemangiomas. And basically, I usually use this when I'm talking to non-radiologists. And what it really underscores is that when you're interpreting all these things, absolutely has to be communication with the referring. Because if you don't have, this of course is an occipital hydrocephalus on a coronal image, but if you don't have the right clinical history, you're going to misinterpret the image. So.